Hello, everyone, and welcome to Question Lab. We're happy to have you here this evening as we dissect questions on the topic of cardiac and cardiology pathology. Leading us once again this evening is Dr. Paras Vakarian, and he's going to introduce himself to us now. Paras.
Thank you, Sean. Hey guys, my name is Paras. I'm a dermatology resident here in Dallas, Texas. I originally graduated from a pharmacy school and then went on to do medical school back in Michigan. I'm also an RX coach with USMLE-Rx, so I work one-on-one with students such as yourselves to help prepare you guys for the USMLE Step 1 and Step 2 CK as well. And I'm happy to help lead tonight's session.
I know I mentioned RX Coach earlier. RX Coach is our coaching and tutoring program where we work with students individually to help them accomplish their goals. And we'll talk more about that later. But what I want you to know for now is that RX Coach, the methodology that we use tonight is the same methodology that we employ in our coaching sessions, okay? So without any further ado, let's go ahead and get into our first question of the evening. You can see that the answer choices are covered up, and that's because we don't want the answer choices to guide or dictate your thought process, and we don't want you to see an answer choice that you're unfamiliar with that may cause you to panic as you're trying to answer the question on test day. So I've removed those for you. After that, we'd like to begin with the lead-in. And we start with the lead-in because we want you to know what the test writer is asking before you read the vignette, so that when you read the vignette, you can pick up on all those relevant clues and not have to reread it and waste time on test day. In our coaching sessions, we usually stop after every sentence and ask you what you want to highlight or what you think is important. We can't do that because we have so many of you today, but I'll pause briefly after every sentence to give you a moment to gather your thoughts. So with that, let's go ahead and begin with that lead-in. Which of the following is a complication of this patient's most likely diagnosis? Which of the following is a complication of this patient's most likely diagnosis? I'll give all of you a few moments here to respond in the question box and let us know how many steps you believe this question will require. An example of a one-step question could be where they ask you for the diagnosis. An example of a two-step question could be where you're asked for the treatment for a diagnosis. And an example of a three-step question is where you're asked for the mechanism of action of a treatment for a diagnosis. So I'll give all of you a few seconds to respond in the question box and let us know how many steps you believe this question will require. And then we'll move on to that vignette. All right, well, I see some responses coming in. So let's tackle that vignette. A 79-year-old man comes to his physician with dizziness and shortness of breath, saying that he can't swim his usual laps without feeling like he is going to lose consciousness. On examination, he has a loud, late peaking systolic murmur at the upper right sternal border and a low volume, slow rising carotid pulse. Which of the following is a complication of this patient's most likely diagnosis? I'll give all of you a few moments to start thinking about what's important in the vignette and lead-in as I hand it off to Paras.
Thank you, Sean. So what we're going to do is we're going to go ahead and walk you guys through what we think are the important clues in this vignette and the lead-in, okay? And so starting off, generally with questions, they're going to give you demographics. And in this case, we have a 79-year-old man. So important to take note of that, especially in cardiology. So right off the bat, with those demographics, you can start to think about certain conditions and start to work through a certain differential diagnosis, okay? So you want to make note of the demographics. You also want to make note of what are their presenting signs and symptoms, okay? So in general, they'll tell you, why is the patient coming to see the doctor? Why are they coming to the emergency room? And those presenting signs and symptoms are important to make note of. And they told us about some of those in this patient. So you want to make note of those as well. And then obviously with cardiology and a lot of other organ systems, physical exam findings are going to be very important, okay? Especially when they're describing things that are heard with the stethoscope, okay? Sometimes they may play an audio file. Sometimes you may have to maneuver that as well. But in this case, they are writing that out for you. So you want to make note of that and use that to pick up on what's going on. So then they're asking us about a complication of the most likely diagnosis. So I think we've got a two-step question here. I think we've got to come up with a diagnosis. We've got to piece together those clues and come up with what we think is the most likely diagnosis. And then two, we've got to figure out what is a complication of that most likely diagnosis. So I think a two-step question here. So let's go ahead and let's take a look at those answer choices that we have previously hidden. What you see here are 5 answer choices. And what we recommend is that when students go through the answer choices, that they actually start at the bottom and that they work their way up to the top. So starting with answer choice E and working your way up to answer choice A. And the reason we recommend this is, a lot of times we'll work with students who, they'll start at the top, they'll see something they like, and they'll select it without having gone through all the answer choices. And sometimes, because of that, they'll get the question wrong. So we recommend doing it this way so you don't make that mistake and so you don't bias yourself. So let's go ahead and let's do that now. Answer choice E, varicose veins. D, pulmonary interstitial fibrosis. C, lower extremity claudication. B, diastolic dysfunction. And A, cholesterol emboli syndrome. So we're going to go ahead and open up that poll. Go ahead and select the answer choice you think is the best answer here, and we'll talk about it in just a few seconds.
Thank you, Paros. As you can see, the poll is now open. Once again, we'll wait until about 2/3 of you have responded before we move on. Remember that on test day, there is no penalty for guessing, so you should never leave a question blank. And certainly no penalty tonight. So if you're unsure what the answer is, don't worry, take your best guess. Then we will review the correct and incorrect answers together in just a moment. I see the responses coming in. Looks like we have a clear favorite already. We'll give all of you a few moments here. All right, looks like 2/3 of you have responded. Let's take a look and see what you selected. It looks like 46% of you selected diastolic dysfunction and 27% of you selected lower extremity claudication. Let's take a look and see what the correct answer is. And the correct answer is indeed B, diastolic dysfunction, and 46% of you got it right. So great job, everyone. Let me hand it back off to Paros. Paros.
Thank you, Sean. Yes, great job with this question, guys. So let's take a look at what's going on. So as you can see, we mentioned that demographics are important. And we've got essentially an 80-year-old man here in this question, so an elderly patient, okay? And when you look at the clues in the vignette, you can see that this patient is having dizziness and shortness of breath, especially on exertion, okay? We know that there's a murmur, and it's a systolic murmur, okay? So when you think of the murmurs that are happening during systole or during ventricular contraction, so aortic stenosis, mitral regurgitation, those would be your left-sided murmurs. And so in this case, we also know that it's happening at the right upper sternal border, which is classically your aortic area, okay? So piecing all those things together, hopefully you guys were able to pick up on that this was aortic stenosis, okay? And with aortic stenosis, you have decreased blood flow that goes across that stenotic valve, so you have less blood flowing across that stenotic valve, which is why during times of exertion, they can present with feeling like losing consciousness or syncope-like symptoms, okay? Let's take a look at the next slide, and this is kind of showing us that aortic stenosis murmur, and you can see it kind of is a crescendo-decrescendo murmur. It kind of starts to get louder, and then it starts to get softer, okay? And this is a murmur that can radiate to the carotids, okay? You can also have a delayed pulse, pulsus parvis et tardus, okay? So in this case, they told us that this patient's pulses were delayed and weak, which is what's going on in this patient, consistent with aortic stenosis, okay? You can also see there that it talks about age-related calcification, and so those demographics are important when talking about heart murmurs as well, okay? If we take a look at the next slide, now we get into diastolic dysfunction, okay? On that, the next slide we can, for like the heart failure, this is one of the tables in first aid. You can see there that diastolic dysfunction is often secondary to myocardial hypertrophy, okay? So what happens is with time, aortic stenosis can cause a heart failure with a preserved ejection fraction. And that's usually because the left ventricle hypertrophies in response to that stenotic aortic valve, okay? And that is because of that high afterload that the ventricle needs to push and contract against, okay? So with time, this can lead to diastolic dysfunction. So potential complication of aortic stenosis. So if we go back to our question, let's take a look at the other answer choices and why those may not be as good answers. So varicose veins, often these are age-related, but usually is due to valve incompetence in veins. So venous valve incompetence, not what you would expect to be a complication of aortic stenosis. Pulmonary interstitial fibrosis, this is a consequence of medications, infections, autoimmune diseases, not so much aortic stenosis. Lower extremity claudication, this is usually caused by atherosclerosis of the lower extremity arteries. So again, a little bit different than what we're talking about. And then cholesterol emboli syndrome, this is usually the result of invasive procedures like an angiography that are trying to dislodge atherosclerotic plaques. Not what's going on here in this question. So great job with this first question.
Excellent. Yes, great job, everyone. Let's move on now to our second question of the evening. Once again, the answer choices have been removed. That is by design, and we will begin once again, as always, with the lead-in. Which of the following cardiac abnormalities most likely caused this patient's symptoms? Which of the following cardiac abnormalities most likely caused this patient's symptoms? I'll give all of you a few moments here to respond in the question box and let us know how many steps you believe the question will require. Then we'll go ahead and move on and read that vignette. All right, I see some responses coming in. Let's take a look at that. A 45-year-old woman comes to the clinic because of a 2-week history of substernal chest pain when climbing stairs, relieved with rest. She has a history of infertility. Her pulse is 82 per minute, and blood pressure is 124/84. Physical examination reveals short stature, 142 centimeters or 4 feet 8 inches tall, and a webbed neck. A 3/6 mid-systolic blowing murmur is heard at the right upper sternal border, and her pulse is delayed. Which of the following cardiac abnormalities most likely caused this patient's symptoms? Faris.
Thank you, Sean. So now we're going to go ahead and show you what we think are the important clues in this vignette and lead-in. And you can see here we've got a little bit of a younger patient, a middle-aged female. Okay, so definitely important to make note of that. Why is she coming in? Well, they also told us that substernal chest pain when climbing stairs that is relieved with rest. A lot of times they'll also give you chronicity in that first sentence as well. Is it acute? Has it been going on for a few minutes? Or is it more chronic? Has it been going on for months? So you want to make note of that to get a sense of chronicity. You know, they also then give us some important past medical history. Again, we talked about the importance of physical exam findings, especially with cardiology. So you can see there that there are some abnormal physical exam findings that we highlighted, as well as some descriptions of that murmur. So almost like you were to be listening to it. What does it sound like and where are you hearing it? Okay. So a little bit more information that is important to take note of. They're then asking us about a cardiac abnormality that most likely caused this patient's symptoms. So I think, you know, this is a little bit of a tougher one to figure out how many steps. I think you could say that there is a one-step, there's a chance this is a one-step question. I think, you know, what's the cardiac abnormality that's causing these symptoms? There's a chance, you know, they could take it a step further and make it a two-step question. It might depend on the answer choices a little bit. It'll be at least one step of trying to figure out what is the heart issue causing these symptoms. Okay, so let's go ahead, let's take a look at those answer choices. And once again, we're going to start at the bottom and we're going to work our way up to the top. Answer choice E, papillary muscle dysfunction. D, narrowed coronary arteries. C, coarctation of the aorta. B, bicuspid aortic valve. And A, atrioventricular septal defect. So we're going to go ahead and open up that poll. Go ahead and select the answer choice you think is the best answer, and we'll talk about it in just a few seconds.
Well, thank you very much, Paris. The poll is open. Once again, we'll wait until about 2/3 of you have responded. As always, we do have a raffle at the end, so make sure you stick around. You might be our lucky winner. As you can see, we're spending time going over the correct and incorrect answer choices. That's something we recommend that you do when you're doing practice questions, to make sure you got it right for the right reason, and also because you can learn from the incorrect answer choices as well. Those explanations provide a lot of information. We'll give all of you a few more moments here. All right, let's take a look and see what you selected. Well, 54% of you selected bicuspid aortic valve, and 31% of you selected coarctation of the aorta. So let's take a look and see what the correct answer is. And the correct answer is indeed B, bicuspid aortic valve, and 54% of you got it right. So great job, everyone. Let me go ahead and hand it off to Paris.
Thank you, Sean. So yes, great job with this question as well. So hopefully you guys picked up on a few things. That one, this murmur is probably very similar to what our last patient had, a systolic murmur at the right upper sternal border, okay, with the delayed pulse. So hopefully you guys were picking up that this is probably aortic stenosis as well, okay? But as you can see, this isn't an elderly patient. So what could potentially be the cause here? Well, they also give us a couple other important physical exam findings: short stature, webbed neck. This is a female patient. So one thing you would want to think about is Turner syndrome, okay? Let's go ahead, let's take a look at the next slide. Turner syndrome, this is a genetic condition where females are actually missing or have a damaged X chromosome. So they actually are considered to have 45 chromosomes and only one sex chromosome. You can see there that they present with short stature. They can present with a bicuspid aortic valve, which is a risk factor for developing aortic stenosis. Okay. You can see that these patients also are at risk of aortic coarctation or coarctation of the aorta, but we'll talk about how that's a little bit different than what's going on here. Okay. And then that lymphatic defect is what presents as clinically what we see as like a webbed neck. Okay, so this patient had a couple of those characteristic physical features that would make you want to think about Turner syndrome. I believe they also told us that this patient has a history of infertility, and you can see there that patients with Turner syndrome often have issues with their ovaries, ovarian dysgenesis, so they often are infertile. So if we go back to our question, hopefully you can see how these clues were present in the question that were just waiting to be picked up on, and that how that bicuspid aortic valve is probably why this patient has aortic stenosis. Okay, so looking back at our question, we can look at the other answer choices to see why those would be less correct. So papillary muscle dysfunction, that would lead to, if anything, mitral regurgitation, and that usually occurs after an MI or some other inciting event. And we're not really told about that here. The location of where we would hear the murmur is also a little bit different as well. That would be more in the mitral area. A narrowed coronary artery. This could cause chest pain, but it wouldn't really explain the murmur. Okay, and patients with narrowed coronary arteries should have risk factors like diabetes, smoking, something that would lead to narrowing of the coronary arteries. Aortic coarctation, we talked about how this can be a complication of Turner syndrome, but this presents a little differently. It presents with elevated blood pressure. You have differences in pressure between the upper extremities and the lower extremities, and we're not really told about those findings, so not as good of an answer choice. And then answer choice A, AV septal defect. This is a finding that's associated with trisomy 21, also known as Down syndrome, and that presents obviously much differently phenotypically. Okay, so in this case, the best answer choice here would be B. So great job on this question as well.
Well, thank you very much, Paris. Yes, great job, everyone. So, if you're finding tonight's session helpful and you'd like to do it one-on-one, and you'd like to have a tutor that would make you a personalized study plan based on an assessment, work with you individually to really identify your strengths and weaknesses, bridge any knowledge gaps that you have, work on your test-taking skills, and make your studying more efficient so you can reach your maximum potential. We have RX Coach. As you know, we've been around for 30 years. We're one of the only companies that was in medical education prior to getting into tutoring. We've authored our own resources, which we'll give you access to. We have our own assessment, which we'll administer to get some data points to ensure that we're studying and using data in progress to guide your success. If you want to work with the coach, reach out to us at rx-coach.com. That's rx-coach or rx-coach.com. Set up a free consultation. We'll talk about the program and how it can benefit you. And that consultation to discuss the program is completely free. And once again, that's rx-coach or rx-coach.com. Let's move on now to our third question of the evening on cardiac pathology. The answer choices have been removed. That is by design, and we will begin with the lead-in. Which of the following is the most likely explanation for this patient's increased difficulty breathing? Which of the following is the most likely explanation for this patient's increased difficulty breathing? I'll give all of you a few moments here to respond in the question box and let us know how many steps you believe the question will require. Then we'll move on to the lead-in. All right, I see the responses coming in. Let's go ahead and tackle that vignette. A 68-year-old man comes to the emergency department with 5 hours of increasing difficulty breathing, dizziness, and fluttering in his chest. He was diagnosed with heart failure with a reduced ejection fraction in the past, but does not take any medications. He is afebrile with a pulse of 135 per minute and a blood pressure of 100/60. Physical examination reveals crackles in bilateral lower lung fields and decreased pulses in all 4 extremities. The troponin I is normal. The ECG is shown. I'll just take a look at that ECG and think about what's important in the vignette and lead-in as I hand it off to Boris.
Thank you, Sean. So we are going to go ahead and show you what we think are the important clues in this vignette and lead-in, okay? So again, demographics. You definitely want to make note of that. Okay, so in this case, we've got a 68-year-old male. He is coming now to the ER, and that's because of some symptoms there, difficulty breathing, dizziness, and fluttering in the chest. And now we have more of an acute issue. So they tell us this has only been going on for 5 hours, okay? You can see that there's some important medical history, some social history there as well. We're given some vital signs, and again, we're given those all-important physical exam findings. We're even given an EKG, okay? So in this question, they're asking us for the most likely explanation for the increased difficulty breathing, okay? So let's go ahead. The next slide is actually a little bit of a blow-up of the EKG, so you guys can take a good look at that. In terms of how many steps is this question, I think, one, we've got to figure out maybe what's going on with this patient, what's the overarching condition for why this patient's difficulty breathing. And then two, maybe what's the mechanism, what's the explanation for why that's happening, okay? So I think probably a 2-step question here. So we'll move on to the next slide, and don't worry, that EKG will still be there in the corner. We'll take a look at those answer choices. Okay, once again, we're going to start at the bottom, work our way up to the top. Right heart failure from pulmonary hypertension. D, distributive shock due to pneumonia. C, development of a reentrant circuit. B, decreased cardiac output secondary to decreased preload with an absent atrial kick. And A, arrhythmia due to acute transmural myocardial infarction. So we're going to go ahead and open up that poll. Go ahead and select the answer you think is the best here. We'll talk about it in just a few seconds, and I'll go ahead and read that answer choice B for you one more time since that's cut off. Decreased cardiac output secondary to decreased preload with an absent atrial kick. And we'll let you guys select your answers.
While the poll is open, once again, we'll wait until about 2/3 of you have responded before we move on. This is our third question of the evening. We have one left afterwards. And of course, then we'll have a raffle and special offer for all of you in attendance. Make sure you stick around until the end because you must be present to win. It looks like once again, we have a clear favorite. We'll give all of you a few more moments here. All right, let's take a look and see what you selected. 45% of you selected decreased cardiac output secondary to decreased preload with an absent atrial kick, and 30% of you selected development of a re-entrant circuit. And the correct answer is indeed B, decreased cardiac output secondary to decreased preload with an absent atrial kick. Let me hand it off to Boris.
Thank you, Sean. So yes, definitely a nice job with this question. So let's take a look at what is going on, okay? So one, we're given an EKG, but we know that this patient has pre-existing heart failure, okay? And now the patient has signs and symptoms of worsening heart failure. Dizziness, difficulty breathing, okay? Crackles in the lungs, decreased pulses. And we also can tell that this patient has some fluttering in the chest. And if you look at that EKG, you can see that it's kind of in what we would call an irregularly irregular rhythm, okay? There's really no discernible P waves in that EKG, okay? And so atrial fibrillation is something that can worsen heart failure because your heart is basically not contracting rhythmically, okay? And you would lose that atrial kick, okay? So if your atria are not contracting normally, and remember, your atria actually, when it does that atrial kick or atrial contraction, that actually helps provide about 15 to 20% of your ventricular volume at the end of diastole, okay? So let's take a look one more time at the next slide, looking at atrial fibrillation. You can see here that it is essentially a chaotic arrhythmia on EKG, and you can't really discern P waves in between those QRS complexes. It's further called irregular because the QRX complexes are not occurring at regular intervals, okay? So those QRS complexes are also at irregular intervals, okay? So if we take a look and go back to our EKG, hopefully you guys are seeing that that's atrial fibrillation. And because of that, because the atria are not contracting rhythmically, we do not get a nice atrial kick that then leads to less volume in the ventricle at the end of diastole. So that means less volume is going to be pumped out by the ventricle. And that's going to equate to a decreased stroke volume, which is equated to a decreased cardiac output, okay? So hopefully you guys understand why that makes, that is the best answer choice here. The other answer choices, so right heart failure from pulmonary hypertension, that would be talking more so about if this was a pulmonary embolism, okay? Then you could explain, that would be an explanation for that with the pulmonary embolism, but we're not really told about anything that would suggest a blood clot. Answer choice D, distributive shock due to pneumonia. You know, there's really not a lot here that points towards a pneumonia. There's not a consolidation on the lung exam. There's no fever we're told about. They were told he's afebrile, so probably not a pneumonia. Development of a re-entrant circuit. This is characteristic of Wolff-Parkinson-White. But remember, with that, you would characteristically see a delta wave or a slow upstroke of that QRS complex, which we're not told about here. And then lastly, an MI, an arrhythmia due to an MI. Remember, we were told that the troponin level was normal, so probably not a myocardial infarction. So nice job here with this question. And we'll move on to the fourth question.
Well, thank you very much, Boris, and great job, everyone. We're doing great tonight. You guys seem to be really, really well versed with the subject of cardiac pathology. So well done, everyone. Let's try to finish strong with our last question of the evening. Here we go. Which of the following serum studies is most likely to be elevated in this patient? Which of the following serum studies is most likely to be elevated in this patient? I'll give all of you a few moments to respond in the question box and let us know how many steps you believe the question will require. And then we'll move on to that vignette. All right, I see some responses coming in. Let's take a look at that vignette. A 36-year-old man comes to the clinic with several weeks of fever, anorexia, abdominal pain, weight loss, and arthritis. Physical examination reveals cutaneous ulcerations and purplish lacy discolorations on the lower extremities. Laboratory results show a serum creatinine of 3.2. The urinalysis is normal. Angiography reveals microaneurysms in medium and small visceral arteries. Which of the following serum studies is most likely to be elevated in this patient? Boris.
Thank you, Sean. So let's go ahead and let's take a look at the clues in this vignette and the lead-in. And so this is our 4th time doing this now. So hopefully you guys are picking up, what are those important clues that you should be taking note of and should be highlighting, so that when you go back and when you process these questions, you really have the most important clues there in your mind, okay? So now we've got a little bit of a younger patient, a 36-year-old male, and they're telling us why he's coming in, a variety of signs and symptoms. But also, they've been going on for a few weeks, okay? The physical exam findings tell us about some dermatologic findings, which I definitely love. And then you can also see there, they give us some laboratory results and some angiography results, all important in trying to figure out exactly what's going on with this patient. They then ask us about a serum study, most likely, that's elevated. So I think, one, we've got to come up with a diagnosis. We got to piece together these clues and come up with a nice diagnosis here. And then 2, what serum study might be elevated? Most likely will be elevated in that condition. So I think likely a 2-step question here. So let's go ahead, let's take a look at those answer choices. Once again, we'll start at the bottom, work our way up to the top. Answer choice E, hepatitis B core antibody. D, antiphospholipid antibodies. C, anti-nuclear antibodies. B, anti-neutrophil cytoplasmic antibodies. And A, anti-double-stranded DNA. So we're going to go ahead and open up that poll. Go ahead and select the answer choice you think is the best answer here, and we'll talk about it in just a few seconds.
Well, this is our last question of the evening. Let's try to finish strong. Next week's topic is pharmacology. We hope you can join us. And of course, we do have a raffle and special offer, so make sure you stick around. You might be our lucky winner. We'll give all of you a few moments here to respond. And as always, we'll go over the correct and incorrect answer choices. All right, a few more moments here. I see the responses coming in. Let's take a look and see what you selected. Looks like 41% of you selected anti-neutrophil cytoplasmic antibodies. And in second place with 22%, we had hepatitis B core antibody. Let's take a look and see what the correct answer is. And the correct answer is E, hepatitis B core antibodies, and 22% of you got it right. Let me hand it off to Boris.
Thank you, Sean. So definitely a tougher question here. So what's going on in this question? Well, as you can see here, that this patient has a variety of signs and symptoms. Fever, anorexia, abdominal pain, arthritis. So you oftentimes in those situations, you want to think about something systemic, okay? Especially when you've got systemic signs and symptoms like fever, weight loss, arthritis, okay? We're told about this purplish lacy discoloration and these ulcers on the skin, okay? We're also told about an elevated creatinine, and we're also told about microaneurysms and involving arteries. And we're told it's not just small arteries, but it's medium arteries as well. So we know that this is at least a medium vessel vasculitis, okay? So hopefully you guys were picking up that maybe this is a vasculitis, and which one most likely would be polyarteritis nodosa. So let's take a look at the next slide, and this is kind of reviewing some of those vasculitides. Okay, so polyarteritis nodosa is a medium vessel vasculitis. It can affect the small vessels, but it definitely will affect medium vessels as well. So patients can present with fever, with weight loss, abdominal pain because the vessels, the blood vessels that feed the GI tract can be affected. Same thing, the blood vessels that feed the kidneys can be affected, so you can have kidney injury. Okay, and this patient did have an elevated creatinine. And you can see there, one of the characteristic findings is microaneurysms on arteries. Okay, so that would be another clue that would point you to polyarteritis nodosa. As you can see there, they talk about hepatitis B is often positive in these patients. So this is something that you would want to check in this patient. If we go back and look at our answer choices, hopefully now that answer choice makes more sense. The other answer choices, so antiphospholipid antibodies would be something, maybe if we were looking for a patient with lupus or was having blood clots and thrombosis. Okay, we're not really told about those classic signs of lupus, a malar rash, photosensitivity, things like that. Anti-nuclear antibodies or a general ANA. A general ANA is pretty non-specific, and it kind of just suggests an autoimmune condition, such as lupus, such as scleroderma. So probably not the best answer choice here. Anti-neutrophil cytoplasmic antibodies or ANCAs. This would be associated with ANCA vasculitides. So microscopic polyangiitis, eosinophilic granulomatous with polyangiitis, your ANCA vasculitides, which is not really what they're pointing at here, but it is something you would be worried about with more of the ANCA vasculitides. Then lastly, answer choice A, this is pointing towards lupus as well. Again, this patient doesn't really have those classic features of lupus. So the best answer here would be E, after picking up that this is polyarteritis nodosa. So definitely a tough question here. Great job overall today, guys. I will hand it back to you, Sean.
Well, thank you very much, Boris, and thanks to all of you. Great job. That was a tough question. Here are the question IDs if you want to take a look at these questions on your own time and review them further. You can simply take a screenshot of this, write them down, and then go into the USMLE-Rx app, enter these in the RX search field, and take a deeper dive.